Gautam sir, can we start the session at 6:30? Am I audible?
Yes, you are, Subhashri.
Good evening, Venkateswar sir. Welcome, sir. Gautam sir, can we start the session at 6:30?
Yes.
Like 2 minutes, right, Gautam?
1 minute.
Yes, sir. We'll start it over, sir.
Okay, sir.
Shall we start?
Yes, sir. Yes, sir. Let's start.
Yeah. So, welcome to all the delegates. It's my privilege to welcome you for this expert session. And gastrointestinal cancer uh, is one of the most challenging and rapidly evolving cancers. And biliary tract cancers, they are not so uncommon on which actually is written in the literature. In India, in regular practice, it will be almost 1 in every 10 cancers that we usually see. It was previously an anatomically aggressive disease. Over the years, over the decades, and over a period of time, it got transformed into a molecularly complex disease. Even the treatment has been, there is a shift in the way we see. We are seeing biliary tract cancers right now as a molecularly diverse cancer, which we need to find out what kind of molecular profile it has. The program was specifically designed to make the audience understand why it is being done rather than how it is being done and what is being done. So we focused on introducing certain topics so that the audience can understand why things are being done. There are a lot of things: management algorithms, surgical decision makings, immunotherapy, genomic profiling, and everything. We will begin the session, and it is a great privilege that AVS sir has joined us today. Sir, I had been an Ekalavya Sishya for you. I had been known you from my BB hospital. I also worked at MNJ Cancer Hospital. He is beyond oncology, and I think he beyond medicine too. A true healthpreneur and a glorious human, has been pioneer in designing clinical trials and in fact bringing many new technologies into oncology. In fact, right now, sir has been awarded a Guinness Book of Record for conducting a session which had many healthcare practitioners in the world. He has bought clinical trials, he has bought artificial intelligence in medicine and especially oncology too. So with this brief introduction, and I sincerely thank AVS sir.
Can, um,
So with this introduction and the stage setting, I will pass over the mic to a bladder cancer and sir will
Thank you very much, Gautam, for such a wonderful introduction. It's indeed great to see you here, and I was very humbled by this. Can I just share my PPT, please? Great. So again, very rightly told by Dr. Gautam that these cancers are not as rare as they used to be. And I think I'm still yet to get the permission to show my presentation. Someone has to stop sharing their screen. Right? Because we have more technologies available. We have more affordability. We have more awareness. These are the three things that made this particular tumors very interesting. The topic specifically given to me is why the gallbladder cancers behave so aggressively. Indeed, that is a question that has been bothering me since 1995 when I was a student studying in BHU. I never saw any gallbladder cancer in the twin states of Telugu states. But when I went there is a sudden surge. Most of them stage 4. Okay, this is a very new thing to us. I never knew that gallbladder cancer exists in such aggressive form. So the learning started almost 3 decades now. Still, the answer is not completely clear. But if we start from the molecules to metastasis, probably I can just put them into 3 buckets. Biology of the disease, anatomy of the organ, lack of awareness, finally lands in aggressive behavior. Most of these slides are based upon the NCCN guidelines, nature reviews, JC1 Global data. So this is my sources for the PPT. The clinical paradox is, it is rare, 2 to 3 per 100,000 population globally. Lethal, most of the times it presents in late stage. 60 to 80% will survive if they are in early stage, but the numbers dramatically fall to less than 5% if they are in advanced stage. There is rule of 5. Professor V.K. Shukla used to tell me. It is the 5th commonest GA cancer. 5-year survival is 5%. Median survival is 5 months. Only 5% of the cases present early. Lastly, you require 5 modalities of treatment. Diagnostics, that is radiology, pathology, surgery, occasionally medical and radiation, and above all, the God's blessings. That's what he used to tell us. Right? So again, the same thing, median survival is around 5 months if it is untreated. The key for this entire aggressive nature is biology, anatomy, and healing. So it is not only delay of presentation, but biologically it is fast. Let's have a look into the epidemiology. In the Ganges belt, somewhere in the UP and Bihar, it's very high. Whereas in the Western Europe, it is extremely low. If you go to Chile, it almost matches the Ganges belt. But if you look at the overall North India, the incidence is 10 per 100,000 population. And if you go down south to Kerala, it is around 1. Some places it is 0.2. And that's what exactly is the spectrum which we are talking about. What contributes to it? In other words, what are the risk factors? Female. Or there is a famous fatty female fate. These are the things that we used to remember as maybe students. So the female itself is a risk factor. Gallstones are associated in 90%, but gallstone is not a causation. Porcelain gallbladder is a known risk factor. You should be very careful. Chronic cholecystitis is a precursor. And if there is an anomalous pancreatico-biliary junction that leads to pancreatic juices pushed up into the bile, that's why the risk factor is there. There is some evidence for the Salmonella and H. pylori as emerging factors. Other than that, a lot of things which we don't know. That's it. Stage 1, in the global, if you look at the data, 10% to 12%. Stage 3, 35%. Stage 4 is almost 50%. So if you look at the T stage, which usually determines the resectability, which our surgical colleague is going to teach you. T1 is excellently resectable, T2 is good, T3 marginally resectable, T4 is usually unresectable. Right? Probably that is the reason why they have a poor prognosis, because surgery is the mainstay of treatment. Most of these people who present early stage are incidentally detected. Then we go a bit lower, that is TNM staging to molecular profiling, that is from histology to molecules. TP53, that is JCO data, this is a combination of those things, is present in up to 70% of the mutation, and it is a driver mutation. RAS in 30%, HER2 10 to 15%, but not that targetable. PIK3CA 5%, CDK and MSI are around 5%. These are the driver mutations. If you look at the signal pathways that are affected, RAS, MAP kinase, PA3K, ATK-mTOR, cell cycle, that is G1S, DNA damage response, what we call as a PARP and other pathways, RET, chromatin epigenetic and Wnt beta-catenin pathways are the 7 pathways which drive this cancer in 96% of the cases. And there is always an overlap and crosstalk between these pathways. If you look how the cholecystitis or gallstones or porcelain gallbladder finally land in gallbladder cancer, initially there are stones which are present in 90% of the cases, produces mucosal trauma, and the traumatic area is irritated by the bile acids. That leads to oxidative stress with a high expression of NFK beta, IL-6, TNF alpha, and COX-2. That leads to accumulation of the reactive oxygens. Again, the body tries to heal with the normal columnar epithelium that transforms into intestinal type. We call it a metaplasia. Again, that is caused both by the bile reflux, pyloric gland metaplasia, and other things. Over a period of time, that slowly transforms into dysplasia with the acquisition of TP53 and RAS activation with clonal expression of the abnormal cells that finally lands into carcinoma in situ and gallbladder cancer. And the final pathway you see is cadherin-Ross's and basement membrane breach that happens. These pathways are not very new to us. They are very similar to what you observe in Barrett's esophagus or ulcerative colitis in colon cancer or Helicobacter causing the gastric cancer. So, we know that there is no one path that drives this. There is multiple crosstalks that happen. So, molecularly it is very complex, and it is very reasonable for us to assume that it is a very, very aggressive cancer. The second problem is anatomy. That is a destiny. The gallbladder is placed without one of the layers which the entire gastric, the tummy contents are having. That is only 3 layers. Its wall thickness is very thin, 2 to 3 millimeters. So it is not a major barrier for the transmural spread. Even T1B sometimes can go up to the muscularis propria. Second thing is, like as I told you, there is no serosa. It is the liver that hides it. And it is in direct contact with the liver, which is the most fertile soil for the metastatic cells to breed and grow. Very importantly, it is very rich in its lymphatic drainage. Even in T2, you have 30% of the cases having nodal mets. So even if you don't find, you have to assume that whether the adequate number of nodes were dissected or whether reported. Surgeons may do a good job, but pathologists may still miss it. And adding to the insult, it mimics cholelithiasis, vague dyspepsia, bloating, jaundice. Unless it is very advanced, it doesn't present. And portal vein is very adjacent, and there is a back pressure that happens in few cases that leads to early hematogenous spread, and peritoneal seedling is the easiest to happen. So that is going to make things even worse. So you have anatomical disadvantage, you have molecular complexities. Then let's see what is happening in and around the tumor. We call as a tumor microenvironment. lot of fibroblasts will come because if you remember in the pathogenesis, the step 2 is secretion of the FGF and IL-6. Stroma is formed. It is like a China wall, which is almost, it's a very thick one that prevents the drugs to enter there. The tumor-associated macrophages will suppress the T cells. So immunotherapies don't act the way they are supposed to act. And T cells are usually exhausted. And there is a reverse mechanism found in up to 20% of the gallbladder cases where the T cell activation is blocked and HAF activation is very common. So finally, what happens as a clinician? You have a dense dysplastic stroma, no duct penetration, nanoparticle delivery is hampered, high interstitial pressures, high PDL expression is found, but still, because the exhaustion of the T cells and then tumor-associated macrophages, 60% of them are resistant. This is what frustrates us. Despite the Topaz and other studies which speak very high about it, even in presence of high PDL, why you fail is because of the two factors. So that is the reason why you don't have too much of objective response rates. Hypoxia-driven metabolism leads to gemcitabine resistance, which can happen very quickly. And low TMB and MSS stable is that thing that usually occurs. Will it stop there? No. Over a period of time, the gallbladder keeps on acquiring new and new clonal mutations, which is going to make our job even tougher, just like a Darwin selection theory. Those which are weak will die faster, and those tumors which are tough keeps on growing. Will it stop there? No. There is a epithelial mesenchymal transition that happens in stage 3, 4, especially, that is loss of cadherins, beta-catenin, claudin, and joy path. So the mesenchymal markers are key. So again, have a quick look. Inflammation, dysplasia, local invasion, nodal spread, liver peritoneal mets and distant mets. This all will lead to the aggressive behavior of the cancer, which frustrates us. Will it respond well to the chemotherapy? No. You have HENT downregulation leads to gemcitabine uptake, which is minimalistic. You have a ERCC1 XPA, platinum resistance, RRM overexpression. Again, that reduces the active gemcitabine pool. MDR genes are present that throws away the gemcitabine. And targeted therapy, as I told you, HER2 amplification is very low. FGFR alteration rates are low. RAF is again low. Off-target resistance is there. IDH, a promise, but never delivered. Immunotherapy, again repeating. Macrophage polarization happens, dysplasia. That's the reason why nothing responds. This is exactly why stage 4 hardly lives for 5 months. The moment mutation starts picking up, that is even in stage 3 resected, hardly people live for 1.5 years. That's it. You have a lot of therapies available, but the moment clonal evolution starts, that is anything beyond T2, you have a tough time. So these are the clinical pearls. High suspicion is needed. Incidentals always have to be, properly, all the gallbladder specimens have to be submitted, even if it is for polycystitis. Early molecular profiling may be the way forward with the new drugs coming up. First line in metastatic, it will be covered by other speakers, so I don't want to spend time. And ensure that you don't miss it. So these are the references for my study. Over to the organizers and Dr. Gautam.
Thank you very much, sir. The entire session has been concentrated on the molecular biology of the tumor. When we study about molecular biology during our course time, we find it gibberish. But as we see the evolution of the tumor, evolution of the treatment, we find out how important it is and how insignificant words in the molecular biology lead into major treatment outcomes in the later thing. That being said, as being medical oncologist, we want to convert every tumor into a chronic condition like diabetes or something. So aggressiveness is primarily molecular rather than anatomical, if I'm not wrong.
Correct.
And sir, do you think that there can be some kind of screening window because we can't uh, leave it being so aggressive? Do you suggest, both as an oncologist and a public health specialist, there can be some screening window in the natural history of gallbladder cancer or some kind of genomic panel test, which can, even hypothetical idea, which can lead us to find these cancers better? Because as you told, if you detect earlier, we give the most survival.
Right. So thing is, rightly asked, Dr. Gautam, uh, ultrasound abdomen is done as a part of most of the health checks,
Yes.
right? Yearly or 6 monthly based upon the possessiveness of the patient, okay, and the
Yes.
policies of the hospitals. Don't ignore the stones, don't ignore the polyps, don't ignore the thickness.
Yes, sir.
Our radiologists have to be trained to have a keen look into the gallbladder, not on the liver. The gallbladder have to be looked keenly, especially if they have the what we call as a classical risk factors like obesity, 40 plus. Those are the people who should be more carefully followed. Number one. Number two, regarding the epigenetic testing, which is coming up and becoming popular very frequently. So we have an advantage that there is only one organ, and that is also not very important. Like it's unlike thyroid. If epigenetic test tells you have a thyroid cancer or breast cancer, will you remove both the breast is a question, right? I mean,
Yes.
you can't act upon an invisible tumor. The
Yes.
tumor has to be visible.
Yes.
In the gallbladder, this is less of a problem. Do I recommend? No, definitely not. Okay. But do I recommend molecular testing? T2 and above. It is worth doing it. Again, will I be able to modify the therapy? The answer is no, but it is always good to have the data that is going to help us in designing future adjuvant trials in a better way. Pure scientific view, because you asked the scientific view, practical view, no. So focus on the gallbladder while screening and molecular testing whenever it is appropriate. 3 and above, I strongly recommend that should be done.
Focusing on ultrasound routine, focusing on gallbladder during ultrasound is the most practical aspect of screening. But thing is that the radiologist also need to be trained in such a way that gallbladder is a major cancer, and it is a major cancer, which can reduce the most of the morbidity if detected earlier. So we come out with the natural history of the disease. We concise search data that if left untreated without any management, a person diagnosed of gallbladder cancer will at last live for more 6 months more. An aggressive cancer will just live for 2 to 4 months. Can we do something out of that? Let's talk with the next uh, expert, Dr. Chaturabhuj Agarwal, sir. So if we can say some treatments or the treatments that we have invented, what has changed? So a treatment which was not done, we just have 2 to 4 months. And now, if some treatment is being given, what can we do more? We oncologists are known to be pessimists, so I just converted into this one. Instead of saying that in spite of treatment, people live for 12 months, I'm just converting that sentence, saying that an untreated patient will live only for 2 months, and some treatment can make it better. How is it made better? The management algorithm of advanced biliary tract cancer will be spoken by our next expert speaker, Dr. Chaturabhuj Agarwal, sir. Thank you for participating in the seminar, sir. It would be great to learn and understand from you.
Uh, thank you, Dr. Gautam, and I would like to thanks organizer for this excellent opportunity and listening to me. And in my coming presentation, I would request you to navigate the slides because the organizing team to navigate the slide, please. Can I have my presentation?
Yes, sir.
Yeah. Yeah. So I don't know whether I'm audible. Yeah. So please, please navigate through. Can you make it full screen, please? Yeah, am I audible? Can you make it fully screen, please?
Yes, sir. Full screen done.
So,
Yes, sir. Yes, sir. Sure.
yeah, it's not still. I can only see the. I don't know whether it's a technical glitch or not, but I cannot see the full screen. Yeah, now it's better, I think. Yes. So today my job is to go through the management algorithm of advanced biliary tract cancer, and we already have got a very good base on which we are going to discuss today. And this is a very thought-provoking topic. So, when we talk of biliary tract cancer, it encompasses a lot of cancers: intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, gallbladder cancers, most of these cancers, they fall into a common subgroup where we treat advanced biliary tract cancer as a part of same disease spectrum. And the most fascinating or the most disheartening thing about biliary tract cancer is the recurrence rate is very high, and most of the patients, they are diagnosed in advanced stage. So let me go through the first slide, please. uh, Subhashri, I cannot, sorry, IT support team, I cannot see my presentation. Is it problem from my end or?
Yes, sir. Give me 2 minutes of time, sir. We will.
Okay, okay, no problem. I will wait then. Am I audible?
Yes, sir. Audible.
Okay, but yeah, so but I cannot see my slides. You are still working on it?
Yes, sir.
Yes, sir. We are working on it, sir. Network issue. Give me a few minutes of time.
Okay, okay.
So just to fill the lapse of network issue. So we have evolved from what's your comments upon what kind of molecular tests and what would be the future of biliary tractor in next 5 years? Where are we going and where are we evolving into?
Yeah, so yeah, Dr. Gautam, a very good question. So if you go 5 years behind, you will see that we only have few options for biliary tract cancer. Like we have capecitabine, we have 5-FU gemcitabine, and some people, they even tried metronomic therapy for biliary tract cancers. But now, as we are going more into era of sequential NGS testing, now the more you test, the more you know. So now
Yes.
when we are testing more, we have seen, I'm going to show in all that in my presentation, that
Yes.
now we have HER2 positive biliary tract cancer, we have IDH mutations in biliary tract cancer. Excellent. So now I can just go through my presentation,
Yeah,
and
yeah, definitely, sir.
I can answer your question.
Yes, sir. Yes.
Yeah, so can we move to the next slide? Okay, thank you. So I have to be little quick because I already lost my 5 minutes. So I'm going to cover my entire treatment algorithm of advanced biliary tract cancer under 6 headings. There is a changing survival. Biliary tract cancer patients, they usually initially they used to die within a year of diagnosis, but now that frame shift is shifting. So changing survival. We are going to talk on chemo IO standard. I will not go into details because those topics are being covered by next speakers. There are certain actionable mutations which Dr. Gautam was asking, and I'm going to cover that in my talk. The sequencing strategy, which is the keynote, which is the key part of my topic. So that how we are going to sequence our therapies. What is the significance of doing next generation sequencing at diagnosis? Now there is no longer a thought process that we do NGS at progression. Now it is being advised that NGS should be done at diagnosis, and we will have a quick review of the evidence. Next slide, please. Yeah. So, what is biliary tract cancer? This part is covered. As I told, biliary tract cancer, it encompasses a wide variety of diseases, including intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancer. And unfortunate thing is, only 20 to 30% patients, they are surgical candidates as presentation, and the majority of the patients, they present with unresectable disease or metastatic disease. And median overall survival with chemotherapy alone, which was historically under 12 months, now we are getting more and more survivors with targetable mutation. Next slide, please. I will quickly have a talk on epidemiology and progression. So almost 210K new cases are diagnosed annually as per Globocon. Most of the patients, they unfortunately die within 5 years, and they die within 5 years, and the 5 year survival rate is less than 5%. And highest incidence is seen in Southeast Asia because of liver fluke infection, and most of them, 70% patients, they had late stage at presentation. Next slide, please. So what makes biliary tract cancer hard to treat? The first important point is anatomical complexity. Their deep anatomical location, biopsy and staging and surgical access is limited. There is dense desmoplastic stroma, so cancer-associated fibrosis generates a fibrotic barrier that limits drug penetration into tumor tissue. Molecular heterogeneity, that has been discussed by my previous speaker, that there is no single dominant driver mutation across all subtype, and it requires subtype specific profiling, which I will be discussing in my subsequent slide, that how the molecular profile depends upon the intrahepatic versus extrahepatic cholangiocarcinoma. And immunosuppressive tumor microenvironment, that is also very important. And rarity, so there is a low global incidence. Most of the patients, they're from Southeast Asian countries, are the part where we see most of the gallbladder cancers and biliary tract cancer. So these all 5 factors taken into consideration: low incidence, anatomic complexity, dense desmoplastic stroma, heterogeneity, molecular heterogeneity, so they make biliary tract cancer hard to treat. Next slide, please. So tumor microenvironment in biliary tract cancer, I think this slide was already covered by my previous speaker, so I will not waste time in this. So we have seen that cancer-associated fibroblast and regulatory T cells, PD-L1 positivity, which is variable 10 to 70%. So all these factors taken together, they create a tumor microenvironment, and that's the rationale of using chemo IO combination therapy. Next slide, please. So now I will come to my topic. What is algorithm for treating advanced disease? Next slide, please. Yeah. So this is how I would like to keep this talk simple in the way that initial evaluation. So first thing what we do is initial evaluation of the patient, which includes history and physical examination. We do all labs tests. We do the fitness profile. We do an initial assessment, and we see whether the patient is ECOG performance status 0 or 1. If the patient is fit for combination chemotherapy, now the first line systemic chemotherapy which is being offered across the globe to most of the advanced biliary tract cancer is gemcitabine platinum based combination plus either durvalumab or pembrolizumab. Durvalumab based upon Topaz trial, and pembrolizumab based upon Keynote trial. However, if the patient's PS is more than or equal to 2, or patient we fit, the treating oncologist feels that the patient has got poor organ function, then the patient may be taken up for systemic single agent chemotherapy, which could be either gemcitabine, capecitabine, 5-FU based, or if the PS is very poor, then patient can be considered for best supportive care. We need to do response assessment every 8 to 12 weeks with either a PET scan or a CT scan. In our part of world, we prefer to do it with a PET CT. However, CT scan is perfectly acceptable. And once we do response assessment at 8 to 12 weeks, further treatment depends upon the response. And we usually give chemotherapy, palliative chemotherapy cycle up to 8 cycles, followed by maintenance of durvalumab or pembrolizumab, whatever patient is receiving or whatever patient is tolerating, up to the maximum tolerable dose. If we talk of second line treatment options, we go to the, so that's either FOLFOX, FOL-free, liposomal irinotecan, gemcitabine, capecitabine combination, GemCap regimen, and targeted therapy if some actionable mutation is identified. So these actionable mutations could be FGFR2 inhibitors. We have pemigatinib and infigratinib and futibatinib for the same. If IDH mutation is detected, we have evolving data on evoc-denib. Although IDH mutation people used to see more commonly in CNS tumors, but now IDH1 is very well identified with biliary tract cancers, and we are regularly testing for IGFR and IDH1 and FGFR2 fusion. If you take specifically FGFR2 incidence, it could be less than 1%. But if we include FGFR as a domain, the incidence goes up to 5%. We can find in up to 5% patients FGFR fusion or rearrangement. BRAF mutation, we have a very good targeted agent, dabrafenib plus trametinib, and believe me, BRAF is a very aggressive mutation found in approximately 1 to 2% patients only. But if you found BRAF mutation, those 1 to 2% patients can, this is a highly targetable mutation, and those patients really benefit with this combination. Anti-RK fusion, I don't have any experience with anti-RK fusion inhibitors, but yes, the data says it can be a good target with entrectinib or larotrectinib. We know anti-RK fusion from the time of lung cancer, but it's very well detected in biliary tract cancers also. And HER2/neu overexpression, which is now being expressed. Initially, HER2/neu was discovered in breast cancer, then extrapolated into lung cancer, gastric cancer, colon cancer, and even in biliary tract cancer, where if it is positive, we can always give trastuzumab or anti-HER2 based therapy. Next slide, please. So this was the management algorithm which I was supposed to speak. And if we go to guidelines, NCCN guidelines, so biliary tract cancer, the primary treatment for unresectable or metastatic disease, if you see the first line treatment options, as I have discussed, gemcitabine cisplatin based combination plus either durvalumab or pembrolizumab. And first line, we always check for the targeted therapy. If there are some targeted therapies which are approved even in the first line, while there are some targeted therapies which are approved in the second line, which I will be covering in my subsequent slides. Considering second line treatment option, NCCN still mentions FOLFOX as the preferred treatment option. But I usually see in my clinical practice, the majority of the reservation of FOLFOX is because the patients have received platinum in the first line, and when I tend to re-challenge them with oxaliplatin, the incidence of neuropathy goes very high. And I practically have never seen any patient tolerating 12 cycles or complete 6 months of FOLFOX or 12 cycles of FOLFOX post gemcitabine and platinum, because most of them, they ultimately land up in neuropathy, and I have to stop oxaliplatin at 6 to 8 after 6 to 8 cycles. But yes, FOLFOX, even FOL-free and regorafenib, these are the well described second line treatment options for biliary tract cancers. Next slide, please. So apart from whatever conventional chemotherapy and chemo IO therapies which I have told, anti-RK fusion gene and MSI, which we have seen if MSI is high, pembrolizumab for tumor mutation burden high, EP-nivo combination, these are all acceptable options. If you have a anti-RK gene mutation, if you have a HER2/neu amplification, or if you have a BRAF gene mutation, or if you have a FGFR2 gene fusion, so these are all the targeted therapies approved. And now we have full agents, so many agents available which were not there maybe 5 years down the line. These options were not there. Next slide, please. Yeah. First of all, we will go for chemotherapy, then chemo-IO combination. I will not go into the details of these trials because these are going to be covered by my next speakers. So gemcitabine cisplatin combination, the ABC02 trial foundation, where we have seen a median overall survival of 11.7 months with a very good significant 0.6 hazard ratio and overall response rate of 26%. So this gemcitabine cisplatin combination is still worldwide practiced as the first line treatment option, particularly for patients those who cannot afford immunotherapy or the patients who cannot afford durvalumab or pembrolizumab. Next slide, please. So, what are the limitations of chemotherapy alone? There is a survival plateau. Median overall survival of 11 to 12 months was there across multiple studies across different population. So, if you see, there was never a time where patients in any studies achieve survival of more than 15 months with chemotherapy alone. So, people who were using gemcitabine cisplatin for more than a decade, they tend to see a survival plateau at 12 months. There was we hardly in our practice we had a patient who survived more than 12 months, but in my practice, yes, we all had few patients, maybe one or two odd cases where patient responded very good to gemcitabine cisplatin for 6 sessions, and then we continued gemcitabine maintenance for approximately another 6 months, but that plateau used to come after 12 months. There is a modest response rate. If we see the response rate, overall response rate is still less than 30%, and complete responses are virtually not there. And cisplatin nephrotoxicity and ototoxicity limit the treatment durations to maximum of 8 cycles. There is no molecular stratification, means if we opt for chemotherapy alone, we are treating all patients in the same group, whether they are FGFR mutant, whether they are MSI proficient or deficient, whether they are ITH mutant or non-mutant. So this molecular stratification is lacking, and salvage therapy gap is there is a huge salvage therapy gap. So these are the main limitations of chemotherapy alone. Next slide, please. Molecular heterogeneity in biliary tract cancer. So as I told, intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancer, these are the three entities, three major entities which comes under biliary tract cancer. If we talk of FGFR2 alteration, it is seen in high percentage in intrahepatic cholangiocarcinoma. If we see for HER2 new mutation, it is seen in high percentage in gallbladder cancer. And if we see HER2, another second combination of HER2 new is extrahepatic cholangiocarcinoma. So there is a sort of molecular heterogeneity if we consider, or if we take these three cancers, or if we compare these three cancers, while anti-RK fusion gene is seen in less than 1% of all subtypes. Next slide, please. So these are the 6 signaling pathways in biliary tract cancer apart from chemotherapy and chemo-immuno combination: FGFR, IDH1, HER2/neu, BRAF, PIK3, and DNA repair, DNA damage repair genes. So this all things.
Meeting.
Yeah. Next slide, please. So this is the approximate incidence. If you talk to me of incidence, that what is the incidence we see? So anti-RK fusion genes is seen in less than 1%, MSI high tumor in 1 to 3%, BRAF mutation in 1 to 5%, FGFR2 inhibition in 9 to 15%, and HER2 new overexpression in 5 to 20% of cholangiocarcinoma, RET fusion in less than 1%, and KRAS mutation in 1%. Next slide, please. Yeah, so this is a very busy slide. It is again shown that FGFR2 inhibition is there. So it can the prognosis is variable, and it is better with targeted therapy if you can find a FGFR2 mutation. If IDH1 is there, the prognosis is very much favorable with targeted therapy approach, and we have IDH inhibitors along with us. If the patient has a wild type of wild types, so then we have to perhaps target them with chemotherapy and immunotherapy. And if BRAF mutation is there, it is very low percentage, maybe in 2 to 5%. Even if I'll say it is less than 2%, but we have now BRAF targeted agents, dabrafenib and trametinib, and we can achieve a very good response. And if the tumor is HER2 new positive, the data is still emerging, but we have lot of anti-HER2 agents for these patients. Next slide, please. So immunotherapy integration. So why to add immunotherapy to chemotherapy? We have seen the 4 limitations of chemotherapy. Next slide, please. So the evidence is Topaz 1 and Keynote 966. I'm not going to go in detail of those trials because it will be covered. So biliary tract tumors, they harbor immunosuppressive microenvironment, and gemcitabine, it induces immunologic cell death and it upregulates PD-L1 on tumor cells. So it primes the immune response. Cisplatin, it increases the MHC class 1 expression and it enhances T cell recognition. And the rationale is chemo-induced immune priming plus PD-L1 checkpoint blockade should synergize to sustain anti-tumor immunity. Next slide, please. This is Topaz 1 three-year trial update. So if you see the extended follow-up, it revealed durable sustained benefit when we add durvalumab. So what we were achieving with chemotherapy was a survival of only 11 to 12 months. The maximum was only 12 months. But when we started adding durvalumab, so the survival went on increasing. The 2 year overall survival went up to, there was almost a doubling of 2 year overall survival. And as you follow up this data more, extended survivors were more and more. And it's a known fact that the patients who respond to immunotherapy, they tend to respond for a longer duration of time. So the separation of curve, they start right from the beginning and they tend to persist over more than 3 years. Next slide, please. So that was one for durvalumab, and for pembrolizumab we have Keynote 966, which has again shown the median overall survival of 12.7 months and 2 year overall survival rate of 24%, similar to that seen in Topaz 1. And the discontinuation rate was approximately 15% due to adverse event, which is most commonly pneumonitis. Next slide, please. So this was the practical comparison. There is no head-to-head comparison between durvalumab or pembrolizumab, but head-to-head comparison, the 2 year overall survival was 23% in Topaz 1 and almost similar 24% in Keynote 966. And the quality of life as compared to chemotherapy was maintained in both the trials. Next slide, please. So we have seen that the chemotherapy standard in biliary tract cancer remains gemcitabine and gemcitabine cisplatin combination. We can add durvalumab based upon Topaz 1. We can add pembrolizumab based on Keynote 966 trial, which have given doubling of overall survival at 2 years. Next slide, please. So now I will come to the targeted therapy landscape, which we have seen that the IDH mutation, FGFR and HER2 new directed therapy, how they have changed the focus of treatment, particularly in subsequent lines of therapy where initially we used to have only FOLFOX. Next slide, please. So 6 actionable targeted mutations, multiple approved agents. We have already seen FGFR2, IDH1, HER2 new amplification, BRAF mutation, anti-RK fusion gene. Next slide, please. So again, treatment selection algorithm, first line, second line is clear. But if you have a FGFR2 mutation positive patient, you don't offer them FGFR agents in the first line. The treatment choice still remain durvalumab plus chemotherapy or pembrolizumab plus chemotherapy. But in second line, you can target FGFR2. If it's a IDH1 mutation, again, the first line remains same. But in second line, you can target IDH2 mutation. Next slide, please. So there is a paradigm shift in survival. Pre-immunotherapy era, the median overall survival was 11 to 12 months. In the immunotherapy era, the overall survival increased by maybe 2 months. But if you see the 4 year and 2 year overall survival rate, there is almost doubling of 2 year overall survival, because the patients who responds to immunotherapy, they continue to respond for a longer duration of time. Next slide, please. So still future directions and unmet clinical needs. There are knowledge gaps and research priorities. So now suppose if you have a patient of intrahepatic cholangiocarcinoma and you do NGS and this is upfront positive, are you going to target FGFR2 in the first line? That is the question which most of the clinicians, as a clinicians, we are facing in our clinical practice. So optimal sequencing of multiple therapeutic modalities, it is still we need future directions on this. How to overcome microenvironmental barrier, that is another barrier. acquired resistance mechanism. Like in lung cancer, we know the resistance mechanism of the like if somebody is on erlotinib and you know T790M mutation and you go give osimertinib, so those resistance mechanisms in biliary tract cancer are still I think most of these are not well documented and well understood. And patient derived tumor organoid models and non-coding mutations and gene regulation. So these are the future directions and unmet clinical need where knowledge gap needs to be filled. Next slide, please. These are the clinical trial landscape and investigational approach which are being explored for future. CAR T cell therapy, Fight 302, Prof 301. I will not go into details of this, but these are some of the future landscape trials which are being investigational still. Next slide, please. And this is the algorithm which I explained. So early biliary tract cancer, we all know, loco-regional, we tend to give neoadjuvant chemotherapy and then we again reconsider for surgery. But my topic is advanced or metastatic, where we do now NGS upfront and we start the patient still on gemcitabine cisplatin-based chemotherapy with either one of the immunotherapy. And then depending upon the mutation, whether it is IDH mutation, whether it is FGFR, whether it is BRAF, or whether it is MSI, or whether it is HER2/neu, we can give second line treatment option as per targeted therapy. Next slide, please. So for learning purpose, this is a very simplified approach of biliary tract cancer. This is how we do. So once we have an advanced disease, first line we start the same and we immediately send the sample for molecular profiling. In absence of targetable action or mutation, we have to give FOLFOX. But if there is presence of targetable alterations, we have 6 targetable alterations which we should keep in mind. And those all 6 targets are very well, the medicines are very well available and they are well documented. Next slide, please. So with all these things, I thank you once again. And if there are any questions, I would be happy to take.
That's a thought-provoking and thoughtful presentation, sir. Thank you very much. So we have improved the survival of advanced biliary tract cancer from 2 to 4 months without any treatment to 12.8 months right now. But the problem is probably we might be treating the patients who naturally do better, more better. And that's the reason for extended survival in the trials that were previously described. But sir, do you still consider that GEMS should only be the backbone? Do you think that additional molecular agents, immunotherapy, and classifying these into multiple molecular subset would actually treat the cancer better? Because we believe in cancer that the first chance we get, hit it as hard as possible. What's your take on this one, sir?
Yeah. So I see. First thing, I just wanted to give one submission. My presentation was I have repeated few things because my presentation was limited to algorithm of treating advanced biliary tract cancer.
Yes.
The algorithm, there is no categoric algorithm. I did a lot of research in finding is there any algorithm. The algorithm always goes. Your algorithm starts with gemcitabine and cisplatin. And I would appreciate if some of the medical oncologists, if they are there and if they differ in their approach. So in adjuvant setting, I have 2 patients, they are on capecitabine, and in metastatic setting, the first line is always goes with gemcitabine cisplatin based chemotherapy. To be very honest, practically we all get most of the patients who are not affording durvalumab and pembrolizumab. So as I mentioned in my presentation, there has been 2 patients which we have given gemcitabine cisplatin for 6 cycles. They achieved very good response, and then we put them on gem maintenance, and they did fairly well for 6 months, approximately 6 months, and then they progressed. So they already achieved a median overall survival of median progression-free survival of 1 year on the first line itself before I switched them to second line FOLFOX. That is one thing. Second thing, like I said, see, what is the practical thing is before maybe 4 years down the line, 4 years before, I was not advising next generation sequencing in the first line. It was always a thought process that we start the first line, and when the patient progress, we tend to search for the targetable mutation. But now what has changed the practice is, even when I see the first patient as metastatic biliary tract cancer, in the first biopsy specimen itself, we send for NGS. That is the change which has happened. But what is confusing is, suppose if I send for the NGS and I have started the patient on gemcitabine, cisplatin, and pembrolizumab, and if the patient is found to have FGFR2 mutation positive or IDH mutation positive, we don't know whether we can really give these targeted agents in the first line, because these agents are still being reserved for the second line. So might be in future we will have more data on these agents. What is the major barrier is the incidence of these mutations are so less, you can't have a phase 3 randomized trial of these mutations versus a standard of care. So that is a major limitation. But I see, if we are more educated, if more and more medical oncologists, they sort of convince patient to do NGS in the first biopsy sample specimen itself, we will find more and more mutations and we will get more data.
Yeah, yes. So basically, there is a concept that mutational changes in they themselves offer some kind of chemo resistance. So it's actually a dilemma. I think close following up of these patients on how they progress will help us to decide whether we can add some kind of targeted agents or not. But still, it's not evidence based. We have to wait for the evidence to start it as soon as possible. And as a take, most of these patients actually die of cholangitis. Ultimately they die
Yes.
of cholangitis, and sepsis is the main cause. Because right now we are doing interventional procedures beforehand, the cause of death might be shifting more towards some kind of cancer progression of hepatic infiltration. With this, with
So
this,
I just want to share one in a quick
well,
this thing, because all patients are not same. So I today in my clinic I had one patient. She's metastatic cholangiocarcinoma with lung metastasis. So when she came to me, she had 4 lung nodules to start with. We have started her on gemcitabine, cisplatin, and durvalumab. And she did fairly well. She tolerated 6 cycles, and we started her on durvalumab maintenance. While on durvalumab maintenance, post 3 months, she developed a single new left-sided lung nodule, which is which was not there previously. Previously, all the nodules were in the right lung. So, but this patient has oligometastatic progression. There was no other site of disease. So we discussed it in our tumor board, and it was decided to give SBRT to the single nodule. So we treated this oligometastatic nodule with radiation, and then we continued durvalumab. So
okay.
this type of things. I mean, all patients, they don't, and the cancers, they don't read books. So
Yes, sir,
this type
that's
of
true.
things also.
And I think that giving SBRT to that nodule is a very good decision, because it will also expose the entire immune system to the antigens, and immunotherapy also can act better. That's an
Yes.
excellent presentation, sir. Thank you very much. We'll take it over to Venkateshwar Kumar, sir. Venkateshwar Kumar, sir, is a surgical oncologist working at Daza Cancer Center. He too is a health entrepreneur. He worked previously at Red Cross Hospital, Nellore, then in Amor Hospital, currently serving as a clinical director for Danza Cancer Center. We are happy to have him. Resectability versus unresectability in biliary tract cancer. He is the only surgical oncologist in this medical oncologist group. I welcome you, sir. I would like to have your insights about how a non-surgeon can decide whether the patient has a resectable or unresectability in biliary tract cancer, and the paradigms are also shifting. There has been emergence of neoadjuvant chemotherapy in first place in resectable cancers and all those things. I'm handing over this thing to you so that we can be enlightened about this topic. Thank you very much, sir.
Yeah, good evening, sir. Thank you, Gautam sir, and the organizers of Indian Association of Integrated Oncology. And thank you for giving me an opportunity to present a talk on this one. I would like to share my screen, please. Are you able to see my screen?
Yes, sir.
Are you able to see my presentation?
Yes, sir.
Yeah. Thank you. Today my topic is the resectability versus the unresectability of the biliary tract cancers. So this biliary tree comprises of this intrahepatic biliary part as well as the extrahepatic part. So the extrahepatic part again divided into a perihepatic part and the CBD part. So in this cholangiocarcinoma, which arises from this bile duct mucosa, can arise starting from the small biliary radicals in the liver up to the common bile duct, entering into the ampulla of water and into the duodenum. So coming to see the overview of the biliary tract cancers, it is grossly divided into a cholangiocarcinoma, gallbladder carcinoma, and the ampullary carcinoma, depending upon the site of origin along the biliary tree. So as we said, this cholangiocarcinoma arising from the biliary tract mucosa, that could be from the intrahepatic part as well as the perihilar part, that is at the hilum of the liver, porta hepatis, as well as the distal biliary tract. So usually these cholangiocarcinomas, they are most common at the confluence of the right and left hepatic ducts, commonly called as the Klatskin tumors. We can see 50% of them, followed by the distal ones comprising about 25% and the remaining intrahepatic 25%. And coming to the gallbladder carcinoma, it is most commonly detected incidentally or in a advanced stage where most of the times it will be unresectable. So this is also a most common biliary tract cancer in some regions of the world, most commonly in northern India, in Native Americans, northern Europe, and some Southeast Asian countries. It is most commonly detected incidentally post-cholecystectomy for some other benign diseases, which the cholecystectomy which are done for some benign diseases. And it is usually 1 to 2% of all cholecystectomy specimens have a gallbladder carcinoma. So there should be some surgical things which we should follow while doing a laparoscopic cholecystectomy to avoid any local spillage or local contamination during the surgery. Usually it will be having an aggressive biology with early lymphatic spread, usually seen in the gallbladder cancers. And the other site is the ampullary region. Usually we call it as a periampullary region, which is about 2 centimeters from the ampulla of the water. All this comprises the periampullary region. In the periampullary region, apart from the bile duct, distal bile duct tumors, we can see the tumors arising from the head of the pancreas, as well as some tumors rarely arising from the mucosa of the duodenum also. But in this context, we will speak only about the distal bile duct cancers. And among all these biliary tract cancers, only 20 to 30% of the cases will be resectable at the time of diagnosis, which is a little bit of less share for a surgeon to do. And coming to this cholangiocarcinoma, intrahepatic cholangiocarcinoma or the extrahepatic thing, depending upon the tumor location and morphology, the aggressiveness depends. So these are grossly divided into mass-forming tumors, which we can show here, and the periductal infiltrating tumors, as well as the intraductal growing tumors. So the most commonly seen things are the intraductal growing tumors. They grow along the mucosa, along the biliary tree, starting from the proximal ducts up to the CBD. And these are the difficult ones to assess the extent of the disease because they will be silently growing within the duct. And these mass forming units, we can detect them clearly in the imaging thing, and we can easily access them and we can easily stage them. And the worst things are the periductal infiltrating tumors. They start in the mucosa, traverse all the biliary tract, and they invade the surrounding organs, whatever are there, causing a lot of fibrotic reactions, fibrosis, inflammation, and the spread to the local lymph nodes as well as the surrounding structures like the major arteries, pancreas, stomach, as well as, invading up to the kidneys and diaphragm also. Coming to the principles of resectability, we assess the resectability in two things according to the oncological staging as well as technical and vascular criteria. Because these are the tumors which invade the major arteries which are very close to them, and they make them unresectable or difficult to resect cases. Coming to this oncological criteria, the resectability depends on the distant metastatic stasis. There should not be any distant metastasis. It should be M0. And depending upon the nodal region involvement, only the N0 or N1 regional nodes are resectable cases. N1 regional nodes becomes the nodes which are at the porta hepatis along the hepatoduodenal ligament, and a few nodes along the common hepatic arteries. These are the nodes which we can resect along with the tumor. And apart from that, N2 nodes, retropancreatic nodes, celiac axis nodes, interaortic caval nodes, all these becomes unresectable. And there should not be any peritoneal carcinomatosis. There should not be any peritoneal disease. So that's why we do a staging laparoscopy compulsory whenever there is a biliary tract cancer, because this peritoneal carcinomatosis is very common in these cases, and we cannot detect them in any type of imaging modalities we use. So that's why staging laparoscopy becomes a very important thing. And many times, depending upon the imaging, we go for attempted resection, and almost 30 to 40% of times we declare them as unresectable when we see for the peritoneal disease or the nodal disease, which will be seen when we start and dissecting during the surgery. And there should be a adequate hepatic reserve. So in the cholangiocarcinomas, intrahepatic cholangiocarcinomas, when we attempt to resect the segments of the liver which are involved, there should be a functional future liver remnant of greater than or equal to 30 to 40% of the hepatic reserve should be there for the resectability. And we should be able to achieve microscopic negative surgical margins. Then only we attempt a resection. And there should not be bilateral involvement of the secondary biliary radicals in the case of hilar cholangiocarcinomas. Even up to the primary biliary radicals in the hilar cholangio, we can attempt a resection. Coming to the vascular, technical and vascular criteria, the vessels which get involved in these cancers are the portal vein, hepatic artery, and the hepatic veins, and the inferior vena cava. So the portal vein involvement up to or equal to 180 degrees or short segment are resectable. And the hepatic artery of unilateral involvement may be reconstructable, and we can attempt a resection in these cases. And among the three hepatic veins, involvement of up to 2 hepatic veins may permit resection, but the involvement of all the 3 hepatic veins, it renders the tumor as unresectable. And inferior cava involvement is generally a contraindication, but sometimes we can attempt a short segment of the IVC resection with a graft whenever there is when that much of resection renders the patient completely resectable. When we are able to attain R0 resection, when we attempted the resection of the IVC, then we can attempt that much of resection. But usually by the time the tumor invades the inferior vena cava, it will become unresectable in all other aspects. And contralateral vascular structures, they must be uninvolved, and there should be an adequate portal venous inflow to the future remnant liver after the segmentectomies. Coming to the resectability assessment in the intrahepatic cholangiocarcinomas, as I said in the previous slide, the resectability depends upon solitary tumors. When there is limited multifocal disease confined to right or left of the liver, and adequate FLR of more than 30%, and there should no involvement of the main portal vein bifurcation, no involvement of all the hepatic veins, and no extrahepatic disease or distant metastasis, M0 disease, and no bilateral portal vein occlusion, and patient fit for a major hepatectomy. As all the biliary tract cancers surgeries or supramajor surgeries, the general condition and ECOG performance score of the patient is also very important to attempt a resection. All these features, they render the case as the unresectable, like the bilateral multifocal disease, the disease in almost all the segments of the liver occupying both right and left lobes, and involvement of the main portal vein or the tumor thrombus in the main portal vein or both the hepatic arteries right and left, and insufficient FLR, functional liver remnant. That means less than 30 to 40%, despite a portal vein embolization. Portal vein embolization is a technique to increase the future liver remnant whenever we are attempting a liver resection also. I'll go through it in the next slides. And when there is a distant metastasis, lung involvement, bone involvement, or when there is a peritoneal disease, as I said, end-to-nodal disease like the para-aortic and celiac node involvement makes the case unresectable, and encasement of all the 3 hepatic veins and medically unfit patient. All these things make it unresectable. Coming to this perihilar and cholangiocarcinoma, usually call it as a Klatskin tumor. The tumor at this confluence of the right and left hepatic ducts, we usually classify using a bismuth colorate classification into 5 types. The type 1 is when there is the tumor in the below the common hepatic duct confluence. Whenever it is not reaching up to the confluence, generally they are resectable. In the typical surgery, we resect entire bile duct along with a partial hepatectomy. In the type 2, it almost reaches the confluence. They are also generally resectable. We resect the complete hepatic duct, CBD, and reconstruct with the hepaticojejunostomies. And type 3A and B, when A is when a right branch is involved, and B is when a left branch of the hepatic duct is involved. These are also resectable in very selected group of patients. So when there is a right branch is involved, we do a right hepatectomy along with a caudate lobectomy. And when there is a left branch is involved, we can resect the entire left lobe, left hepatectomy along with a caudate lobectomy. And the last one is the type 4, in which both the right and left hepatic ducts are involved, or when there is a multifocal involvement, there is skip lesions in the entire biliary tract, starting from the distal CBD, hepatic duct, right and left ducts, as well as in the intrahepatic ducts. Usually these cases are unresectable total. In these cases, we can consider for a transplant in selected patients. Coming to the distal cholangiocarcinoma, which is in the distal CBD or the distal common hepatic duct, as well as in the gallbladder cancer, the resectability is assessed in the form of when there is no involvement of superior mesenteric artery or the celiac axis, and when there is portal vein or superior mesenteric vein short segment involvement, which can be reconstructable, no distant metastasis, no para-aortic nodal disease, then only we can attempt a resection in the form of Whipple's procedure, pancreaticoduodenectomy. Superior mesenteric axis involvement, celiac axis encasement, distant metastasis, peritoneal disease, and bilateral hepatic artery involvement, it makes the distal cholangiocarcinoma unresectable. When coming to the gallbladder cancer, the T stage of the tumor also can be used to assess the resectability. So T1A and T1B confined to the mucosa and the lamina propria of the gallbladder layer. In T1A, the cholecystectomy alone can be sufficient, or in T1B also in simple cholecystectomy with R0 resection is sufficient. Usually, most of the times, in incidentally detected gallbladder carcinoma in a lab cholecystectomy specimen done for a biliary, cholelithiasis or the gallbladder polyp or the sludge. Usually, when we detect a T1 or T1B disease, usually we don't attempt any further resection or any other treatment. When it comes to the T2 tumors, which invades the perimuscular region, a re-resection with or without a segment 4B5 of the liver resection as well as a lymphadenectomy. Generally, we call it as a radical cholecystectomy. So we re-resect the gallbladder bed along with the 4B and 5 of the 5 segments of the liver, as well as lymphadenectomy, the local lymphadenectomy up to the N1 disease and N1 nodes. The T3 tumor, which is invading the serosa of the tumor as well as the surrounding liver, we can attempt a major hepatectomy along with lymphadenectomy. Usually in gallbladder carcinoma, in the radical cholecystectomy, we resect segment 4B and 5, and sometimes it may be extended up to the 4A as well as in the segment 6 or the caudate lobe when we are when we are able to achieve a negative margin by resecting those extra segments also. And the T4 tumor involving the portal vein or the hepatic artery or the surrounding structures, they are usually unresectable. So in the gallbladder cancer, most of the cases, if they are incidentally detected, they come in a T1, T1B stages. And if it presents by itself, usually they are T4 lesions. Incidental gallbladder carcinoma, if bile spillage is occurred or margins are positive, re-resection is mandatory, and port site excision may be required, but port site excision will not add any advantage in the overall survival of the patients. And imaging to exclude M1 disease before the surgery is a must. Vascular involvement and the decision framework depending upon the involvement of the all around encasement of these vessels. When coming to the portal vein, less than or equal to 180 degrees contact, it is generally resectable. When the borderline cases, when there is a short segment occlusion and less than 180 degrees encasement, usually we can resect a short segment and can be reconstructed with a graft, a Daflon graft or something like that. More than 180 degrees involvement, long segment involvement, or portal vein involvement, complete thrombus is usually generally unresectable. And main portal vein trunk involvement is an absolute contraindication. Coming to the hepatic artery involvement, unilateral involvement is usually resectable. Short segment, which is amenable to reconstruction, is also in a borderline setting. It is resectable. And bilateral involvement and celiac axis encasement, complete encasement, makes it a complete contraindication. And hepatic vein, in the case of hepatic vein, single vein involvement, usually it is generally resectable. It can be resected along with that segment of the liver or the trisegmentectomy of the liver. Whenever the two veins are involved, and even in this case, if there is a future liver remnant of more than 40%, which is adequate for the survival, then also we can attempt a resection in this case. And when all the three veins are involvement, or when there is an IVC involvement, it is an absolute contraindication for the resection. Coming to the future liver remnant and the portal vein embolization techniques, the thresholds for the safe hepatectomy, depending upon the future liver remnants, depends upon the basic or the background liver of the patient. If the background liver is cirrhotic, we have to have a 50% of the future liver remnant, because already the half of the liver is compromised with cirrhosis. When there is an underlying liver disease, FLR should be 40%. When there is a previous chemotherapy exposure, when we attempt a systemic therapy before the surgery, then also we should expect 30%. And when there is a completely normal virgin liver, it is the 20% of the future FLR can also sustain the patient in the postoperative period. So to increase this future liver remnant, there are few techniques which we use before the surgery to increase that FLR, and that is called as a portal vein embolization. So FLR below threshold for safe resection, it is an indication for the portal vein embolization. And the mechanism is the contralateral lobe atrophies, ipsilateral remnant hypertrophies, up to a percentage of 40 to 70% volume gain will be there. So when the disease is on the left side of the liver, we occlude the portal vein, and slowly the blood supply to the right half of the liver increases, and gradually the right half of the liver hypertrophies, and the volume of the liver increases. And we wait for 4 to 6 weeks before reassessment after a portal vein embolization. And greater than or equal to 5% gain suggests an adequate response, and non-hypertrophy may indicate occult liver disease or the progression of the disease. And one more technique called as the ALPS, which is associating liver partition with portal vein ligation. It gives the advantage of a faster hypertrophy, but there is a higher morbidity for this procedure. Yeah, when it is used only when portal vein embolization is inadequate. So the assessing the resectability and assessing the staging at the initial presentation itself is very important to decide upon the resectability, because even though 20 to 30% of the cases present in a resectable condition, even then the surgery is the best chance of cure for these patients. So assessing in the preoperative setting itself, the resectability versus unresectability is very important. So usually in the lab workup, we do liver function test, GCT, ALP, tumor markers, CA19-9 and CEA. AFP is done if there is an intrahepatic cholangiocarcinoma, because very rarely, in 1 to 10% of the cases, intrahepatic cholangiocarcinoma may coexist along with an hepatocellular carcinoma. So there will be some mixed tumors in those things. The trend of the bilirubin we observe and coagulation profile. And coming to the cross-sectional imaging, which we use to attain the to assess the resectability, we use triphasic CT of the chest, abdomen, and pelvis, multiplanar CT, and MRI and MRCP to assess the biliary anatomy, and PET CT usually for the metastatic staging, nodal staging, as well as the local staging. We don't get much information in the PET CT scan. The triphasic CT itself or the MRI MRCP is more useful in the local staging as well as the nodal staging. PET CT helps in distant staging when the tumor spreads the lung, bones, or all those things. And 3D volumetry is also very important to assess the future liver remnant. And the biliary assessment, we used to do it with ERCP, percutaneous cholangiography, or breast cytology, and feces study of the breast cytology to know the malignant cells in the cytology fluid, and cholangioscopy in selected cases. Endoscopic ultrasound guided FNAC of the surrounding nodes to assess the nodal stages. Percutaneous biopsy can be attempted when the case appears to be unresectable, and diagnostic laparoscopy is a must to assess the peritoneal disease, because the cross-sectional imaging usually won't help much to assess the peritoneal disease, and peritoneal washings when we do a diagnostic laparoscopy. And a preoperative biopsy is not always necessary before proceeding with a definitive, potentially curative resection. So when there is a clinical strong suspicion that usually we see in the gallbladder tumors, clinical suspicion that it is a malignancy, then there is no point in doing attempting a biopsy to confirm the disease, rather than doing a curative resection is the best thing we can do in these cases. Definitely, there should be a multidisciplinary discussion before the start of the treatment, which should be comprised by hepatobiliary surgeon, an oncologist, radiologist to assess the resectability in the cross-sectional imaging, interventional radiologist, and a pathologist. Coming to the borderline resectability and downstaging the strategies, as we discussed, there is a situation where some tumors are borderline resectable when the encasement is more than 180 and a short segment is involved, vascular involvement. Then also we can attempt a resection when we downstage the tumor using some strategies like the systemic therapies with the GEMSIS and immunotherapy, which is already discussed in detail, and loco-regional therapies like the transarterial chemoembolization techniques. In this setting, we take the help of the interventional radiologist, hepatic arterial infusion with a chemotherapy drug in the case of intrahepatic cholangiocarcinomas, SBRT, stereotactic body irradiation, and selective internal radiation therapy using yttrium-90, and biliary drainage prior to the neoadjuvant therapy if the patient is jaundiced. All these local regional therapies we use to downstage the tumor, rendering the borderline resectable disease to a resectable condition. And surgical augmentation of the liver remnant with the help of, as discussed, portal vein embolization, ALPPS, it is a rapid two-stage hepatectomy, which hypertrophies the remnant liver in a short time when compared to portal vein embolization, and contralateral bile duct drainage prior to the resection, and vascular reconstruction and portal vein grafting whenever it is possible, and staged hepatectomy for a bilobar disease. All these surgical augmentation procedures, they also render the borderline resectable disease into resectable condition. And coming to the key survival data, when after attempting a surgery, 5-year survival, which is most commonly and which is well seen in periampullary cancers. So after a Whipple's procedure, which is R0, where we can attempt a R0 resection, and which has been resected to a microscopic negative margins, almost there's 55% of survival is achieved at 5 years when there is an R0 resection, and only 20% when there is R1 or unresectable disease. And the perihilar cholangio is the lowest with 25% of the 5-year survival. And the key prognostic factors in these cases are the R0 margin status. As we discussed, it is the most important determinant of the survival. Lymph node involvement significantly worsens the prognosis. Perineural and vascular involvement, it predicts the recurrence of the tumor and grade of the tumor and the volume of the resection. Liver function reserve matters. The FLR, the percentage of FLR really matters. And the molecular biology of the tumor, like the IDH1, FGFR2, KRAS, they are becoming increasingly important because a lot of improvement in the systemic therapy in the form of monoclonal antibodies, targeted therapies, and adjuvant capecitabine, it improves the overall survival in resected biliary tract cancers in an adjuvant setting, as proved by the BILCAP study. And the presence of jaundice in a gallbladder cancer, it usually portends a poor prognosis. So attempting a biliary drainage by doing an ERCP or any other or percutaneous cholangiography before attempting a resection is a must to improve the survival of the patient. And coming to the summary and the take-home messages for the today's talk, the resectability is multidimensional. It is determined by the oncological aspect, vascular aspect, volumetric aspect of the liver, and patient fitness criteria. And only 20 to 30% of these biliary tract cancer patients, they present in a resectable condition, and therefore rigorous preoperative staging is essential in all the cases. And Bismuth colorectal classification guides only hilar cholangiocarcinoma planning, but the vascular and biliary anatomy, it must be individually assessed. And R0 resection remains the primary treatment goal whenever possible, and the strongest predictor of this is the long-term survival across all the types of biliary tract cancers. And borderline resectable disease should be discussed in a multidisciplinary setting before proceeding to upfront or delayed surgery. So this is the importance of the multidisciplinary discussion in these type of cancers. And FLR augmentation using portal vein embolization or ALPS technique, and downstaging regimens, surgical augmentation, interventional radiological procedures, and systemic therapy, all they can be used to downstage and convert a borderline tumor to a resectable tumor in selected patients. And adjuvant capecitabine and emerging molecular targeted therapies, they are all reshaping the perioperative landscape of these critical biliary tract cancers. A multidisciplinary hepatobiliary tumor board remains the cornerstone of every treatment decision taken in this type of cancers. Thank you so much.
Thank you very much for the thought-provoking presentation, sir. You have really given us clue on resectability and resectability. The advances both in surgical oncology and vascular surgery especially, have pushed the limits of surgical resectability in pancreatic cancer, if I'm not wrong.
Yes.
But we need to remember, I hope most of the oncologists agree, that biology is more, uh, biology predicts the survival more than the anatomical part of the. Why I pose this controversial question is, sir, in your opinion, do you think that neoadjuvant therapy, which has already been a standard of care in pancreatic cancer, a close relative of biliary cancers, should also be some kind of standard in biliary tract cancers? So you see a cancer which is resectable, though difficult. Do you think that a neoadjuvant chemotherapy will actually improve the survival of the patient?
Yes, sir. In clear resectable cases, attempting the surgery at upfront is the best chance of cure to the patient that we can give. And whenever there is a technical difficulty, or whenever there is a suspicion of borderline resectability, subjecting the patient to neoadjuvant chemotherapy or neoadjuvant systemic therapy is the best thing we can do. In that way, we can downstage the tumor. As I said, we can render the tumor borderline resectable to resectable condition. So definitely, that is a decision to be taken in the tumor board for a neoadjuvant chemotherapy in borderline locally advanced disease.
Yes, sir. Recently, we are seeing a trend that which appear to be locally advanced upfrontly. We start them with immunotherapy and gemcitabine and cisplatin. Few patients eventually become resectable. Probably
Yes.
in the next few years, we'll have enough evidence that the tumors are targeted biologically before they are resected anatomically. Anyway, that was a wonderful presentation, sir. Thank you for your insights. Next,
Thank you, sir.
again, it is International Association of Integrated Oncology, and oncology is never practiced alone. It is practiced hand in hand with surgical oncologist, medical oncologist, radiation oncologist, and lately we are involving a molecular biologist also into tumor board, because cancer is a genetic disease and genes determine how cancer behaves and how my treatment works. That's the reason while we design the seminar with the help of International Association of Integrated Oncology, we made sure that we have a molecular oncologist in our team to give insights and to help us understand the molecular biology of the disease. With this small introduction, I'll pass upon to Amit Roy Chaudhary, Assistant Director and Molecular Cytogenetics in DNA Life Sciences Private Limited from Bhubaneswar. Thank you very much for joining us, sir. It has been a privilege. I hope you give us enough insights to understand it better. Thank you very much, sir.
Thank you so much, sir. On the onset, a very warm good evening to all the members, my fellow speakers, faculties, and IAIO for giving the opportunity, and of course, Dr. Gautam for wonderfully organizing this program. And I also thank all the attendees who have joined in lately and been patiently waiting and listening. I'll quickly share my slide. Just to confirm, are my slides visible?
Yes, sir. Visible.
Great, thank you. Okay, so the topic assigned to me is basically role of molecular profiling in cholangiocarcinoma. So my job has been cut out very significantly because of the wonderful talks we have had from Dr. Suresh, Dr. Agarwal, and just now with Dr. Kumar. So I'll not waste of a time, and for my audience, I'll quickly just touch upon the basics that if somebody has missed, that biliary tract cancers include cholangiocarcinoma, and that is CCA, will be calling it as, and GBC. So now, as per the anatomy, CCA is further categorized into intrahepatic, perihilar, distal, and in the biliary tree, as we have heard from Dr. Agarwal. So among these types, PCA CCA is the most prevalent type, accounting for 50 to 60% of CCA. Now, CCA accounts for approximately 15% of the liver cancers and approximately 3% of GI malignancies. Now, why these numbers are important that we are going to discuss in the upcoming slides, because they'll tell you how mutation profile is important in specific subset of CCA. Now, often diagnosed at advanced stages due to various regions, which has been nicely described by Dr. Suresh, and hence the median overall survival remains very poor, often 12 or less than 12 months. So just to summarize and just to see what I spoke in the previous slide, that the overall incidence rates, as we see, is high for the extrahepatic cholangiocarcinoma, that is around 50 to 60%. GBC is around less than 4%, and intrahepatic is around 10 to 20%, wherein treatment regimen classically follows surgery, radiotherapy, chemo, and IO is coming up with PD-1, PD-L1, and CTLA-4 inhibitors, and targeted therapy, of course, with the detected mutation types, specific mutations in the classical subtypes. Now, the point is the risk factor. So as highlighted in the European and American context, we see obesity is a challenge, which puts the risk factor in the patients for developing CCA, CA, and but in Southeast Asia, it's the infection with the flukes, liver flukes. But obesity is no doubt is rising in India as well. So that is another point to be considered. So what is the importance in molecular profiling cholangiocarcinoma is basically, see, the sample type is very important, what we choose and when we choose. So the tumor, that is somatic sample or blood, maybe liquid biopsy collected in a plasma preservative tube, and for monitoring and in advanced stages. And these mutations often encounter and encapsulate the various variations happening, like single nucleotide changes, copy number variations, reagents, rearrangements happening in these genetic alterations. Now, if what happens is this allows us targeted treatment option for a specific mutation type and sample in different patients. Now, important point to be noted, which Dr. Agarwal highlighted, I liked it, that no two cholangiocarcinoma tumors are exactly the same, even though they are arising on the same place. So the mutation profile becomes very important in such scenarios. So now molecular profiling enables identification of actionable genetic targets, which facilitates precision oncology for guiding therapies, now which allows therapeutic outcomes to improve in these patient types. Now, what techniques do we harbor? So now, as we speak, my previous speakers have already discussed about NGS, but there are other modalities as well. Now, I'll touch upon the intricacies of these techniques and where we face challenges. So basically, sequencing allows us DNA-seq and RNA-seq. DNA-seq is mostly for detecting the point mutations and amplifications, whereas RNA-seq, we use it for all the fusions that is happening. So, for example, I have put it NTRK and FGFR2 fusions. And for amplification for HER2/neu, for such cases where HER2/neu renders to be unequivocal in IHC. So now in liquid biopsy, it is very minimally invasive and for mostly used for tumor monitoring. So around 7 to 8 ml of peripheral blood can be collected, and the cell-free ctDNA can be isolated. So ctDNA is often challenging to isolate and to quantify, because the levels detected in the bloods were quite minimal. So approximately the WAF that we consider in such cases for doing NGS is around 0.1 to 1%. So that is very important and critical to call out the positivities in such scenarios. And then classical IHC for using HER2/neu and MMR protein evaluation. So, and lastly, FISH for doing all these. So the thing I have put in this slide is basically we see that NGS can target the point mutations, fusions, as well as amplifications in one go in a single panel. Whereas in a resource constraint setting, or in economical challenges in specifically in this part of the country where patients cannot afford, then we can look for targeted mutations. If NGS is not feasible, then we can go for targeted options like FISH IHC based detections. So now let us look at what NCCN has to say. So this I have adapted from the recent 2025 update from version 2 from for NCCN clinical practice for biliary tract BTCs. So it highlights all those 6 most prevalent mutations, those to be screened in CCA and BTCs, that is NTRK fusions. Again, NTRK fusions and FGFR2 fusions the incidence rate remains very low. So, but MSI detection through IHC or through sequencing is the choice, and BRAF valine 600 to glutamate change is the hotspot mutation that is often checked. Again, it is a targeted mutation, and then IDH1 variants which are detected, and HER2/neu screening. Apart from these, there are other biomarkers as well which are being studied, like TP53, RET, ROS fusion, then KRAS G12C mutation, targeted mutation, and other KRAS mutations, and tumor agnostic markers in different cancer types as well, which are known to be oncogenic. Now, the common mutations or profiles that generally often seen are presenting with the frequency that IDH1 mutations, that is approximately 10 to 20%. FGFR2 fusions are found reported in the literature in intrahepatic CCA to be 10 to 15%, then followed by BRAF 5 to 15, and MSI is generally stable, and it is are very unlikely scenarios or unusual scenarios we get to see a high. So what does MSI high signify is basically loss of expression for any of the two molecular targets for like MSH2, MSH6, or MLH1 or PMS2. In those cases, a mutation profile can be done to rule out, or a hypermethylation status can be seen to rule out whether MSI is actually high, or it is a QC error which has happened while processing the tumor samples in a primary lab. So in BRAF mutations, again, for these, the relevance, clinical relevance, and their targeted therapies are highlighted. I will not go into that. My next speaker is covering those in detail. And the CCA mutation profile based on the different anatomical region of CAA is basically in the extrahepatic region. We mostly see your TP53 mutations, HER2/neu, SPIK3CA mutations, and whereas in in intrahepatic we see FGFR2 fusions, IDH, and DAP1 mutations. And GBC presents with HER2/neu and PIK3CA predominantly, which is adapted from Rizzo et al. Published in Cancer Control. Additional highlights can be found in the DOI presented. So the challenges that we mostly face in a molecular biology lab is the tumor heterogeneity. So because tumor diversity and different tumors present complications, for example, clonal evolution, where there are two clone evolving with treatment, or for subsequent divisions happening in the cell and the cancer stem cells and evolving. In such cases, the tumor population becomes heterogeneous, and the tumor detection, the mutation detection in those cells becomes challenging to report because of their incidence type. And then also depending, because CA is encapsulated with different organs similarly, like hepatocytes, then your gallbladder, pancreas. So tumors from different sites or at metastatic stages, it becomes challenging to rule out whether the tumor percentage and the VAF calling becomes challenging. Then sample quality, so biopsy techniques and the tissue handling in the primary labs is often, I have encountered personally, is most challenging in the lab, because most of the time tumors present with poor DNA quality and RNA quality due to poor processing in the primary labs, which becomes challenging. And then low incidence of mutation. So what happens is there are certain mutations which are detected but are not reported. So in such scenarios, we generally recommend follow the ACMG guidelines for calling out the pathogenic, likely pathogenic, and VUS variants. So VUS variants are again little problematic, or creates a dilemma whether to treat the patient or not consider the mutation based on the mutation type detected. But as ACMG highlights that all the nonsense mutations, that is protein truncating mutations, to be classified as a pathogenic mutation. So that helps in classifying the mutations based on bioinformatic analysis, additional bioinformatic analysis, and allows subsequent classification of the mutation. But VUS remains a gray area, because for the newer mutations which require clinical and bioinformatic validation to classify them as pathogenic or likely pathogenic. So that's it from my side. I'll be happy to take more questions. Thank you.
That is again an insightful presentation, sir. So the thing that is stopping us from ordering NGS right now is the cost of the
Yes, very correct.
panel. Cost of the panel. I think with more number of labs and newer technology, NGS will become as affordable as any histopathological test. We can design some panels through fish and then decide upon whether it is positive or not. But cancer is more a genomic disease that is determined by interactions with many other changes.
Agreed. Agreed.
So I don't think just by identifying the targeted mutations, we can actually understand whether the drug works or not.
Yes.
An NGS panel or exome sequencing, if required, will help us to get that data, which will make us understand how all these genes interact and what would be the final result. I think in near future, and it's already being tried, that people are now using therapeutic genomic data also, where they are testing the drugs beforehand before they come out. That's an insightful data, sir. Thank you for the presentation. It was in-depth and I could really make many things about it.
Thank you so
And
much, sir. I completely agree with you. I'll add on that I completely agree with the points raised by you and suggestions given. And the NGS is here to stay, and it will soon become a mainstream. Just like as you said, like the routine tests we are doing, and the bigger tests like CGPs, comprehensive genomic profiling, or TMBs, molecular tumor burden we are doing, considering the MSI status and the mutation burden load, that itself covers 500 plus genes in the panel. So not just seeing the targeted mutations, we have to also look at the corresponding or coexisting mutations which can alter or make the patient either resistant or sensitive to the therapies that we're planning to give.
yes, sir. That's what that is trending all these days.
Yes.
That a genomic sequencing, in fact, whole exomic sequencing and the molecular tumors and the things are coming.
Correct.
And all these things have happened, which led to what we are right now in biliary tract cancers.
Completely agreed.
So thank you very much, sir. And the next topic would be on targeted therapy. I termed it as revolution because revolution is an immediate, more significant change. For whatever that has happened in biliary tract cancers, rather than chemotherapy, rather than surgery, targeted therapy showed us aspect of life, and with lot of courage and confidence, I do say, it was a single therapy or single point which has changed the survival more than the other treatments. The backbone is still chemotherapy. We add immunotherapy, but I hope with the kind of things that are happening all over the world in therapeutic discovery, targeted therapy is the one which will change the prognosis of cholangiocarcinoma for better. I would like to invite Dr. Siddharth Lath, consultant medical oncologist at HCG Asta Cancer Center, Ahmedabad, to give his insights, shed some light, and help us understand targeted therapy in cholangiocarcinoma. Welcome to the conference, sir. I hope your insights will help us to understand things better.
Thank you, Dr. Gautam. Thank you, IAIO, for giving me this opportunity. Can I have my slides, please?
Yes, sir.
So, basically, we have discussed most of the important aspects of cholangiocarcinoma or biliary tract cancers in the previous slides and previous discussions. And we have a lot of discussion about the genetic aspects of cholangiocarcinoma in the previous discussion by Dr. Amit also. So we'll just go for a quick discussion or review of the aspects. Next slide, please. Next. So basically, as we all know, anatomically, cholangiocarcinoma is now divided into intrahepatic cholangiocarcinoma, which forms about 90% of cases. And then we have hilar cholangiocarcinoma according to the new terminology, and distal cholangiocarcinoma, which are usually described to as extrahepatic cholangiocarcinoma. Next. So basically, we all understand that there is a rising incidence of cholangiocarcinoma because of the etiological agents. There could be some uh, uh, most of the cases of cholangiocarcinoma would be idiopathic, but in some cases, for example, due to obesity or the rising incidence of metabolic syndrome, chronic inflammatory diseases like hepatitis B, C, alcohol consumption, smoking, and due to infection in Southeast Asia region, mainly from clonorchis or opisthochis, then IBD and Caroli's disease. These can lead to a rise in incidence of cholangiocarcinoma or developing cholangiocarcinoma. Next slide, please. Next. So this is a graphic representation of a rise in the incidence of cholangiocarcinoma. Next. So coming to the treatment part, which is to be discussed in this presentation, basically we understand that in the initial cholangiocarcinoma would basically be divided into resectable and non-resectable cholangiocarcinoma. And resectable cholangiocarcinoma would go for staging laparoscopy followed by upfront resection. And then it would subsequently go for adjuvant chemotherapy plus minus targeted therapy or immunotherapy. In unresectable cases, we'll go for, depending on the presentation, usually we start with chemotherapy, that is systemic therapy. And upon failure on systemic therapy, we go for targeted therapy. One thing has to be understood that as we start chemotherapy, we have to simultaneously go at, there is always a debate as to when should we go for DNA testing or genomic profiling in biliary tract cancers. See, the current status is that it would be better if we go for genomic testing in the upfront setting rather than waiting for the failure of the patient on chemotherapy. But as of now, as we will see in the subsequent slides, we do not have an evidence to support starting targeted therapy upfront. In metastatic setting, also we will start with a systemic therapy and then go on to add targeted or immunotherapy. Next slide, please. Next. So basically, as we can see the treatment patterns, this is the usual treatment pattern we follow in our treatment algorithm or in clinics. We usually start in patients who are suitable candidates for chemotherapy with chemotherapy, which usually consists of gemcitabine containing regime, or in some cases 5-FU containing regime. Upon failure of the first line therapy, we move on to an alternate chemotherapy regime plus minus targeted therapy. It is to be noted that now we have Topaz 1 evidence. So in many of the patients, we can start with immunotherapy in the first line. See, it is always discussed whether we start with the targeted therapy in the first line, but because we do not have strong evidence, we do not start with targeted therapy in the first line. We do start with immunotherapy, that is durvalumab or pembrolizumab in the first line, but using targeted therapy in the first line is still not there. We can also note that 85% of patients initiate gemcitabine-based chemotherapy as their first-line therapy. But only about 46% of patients go on to get second-line treatment, and which is usually 5-FU-based regime if gemcitabine-based regime has been given in the first line. And then only 17% of patients go on to receive the third line of therapy. It is also to be noted that the median duration of treatment also keeps on decreasing as we move from first line to second line or to the third line. Next slide, please. So basically, this is a presentation. This is a graphical representation of the anatomical division and the genomic alterations we find in cholangiocarcinoma. Basically, cholangiocarcinoma is now divided into intrahepatic cholangiocarcinoma, which is subdivided into small bile duct intrahepatic cholangiocarcinoma and large bile duct intrahepatic cholangiocarcinoma. Intrahepatic cholangiocarcinoma as such has the highest propensity for TP53 mutation, that is 27 to 40%. And then it is followed by IDH1 mutation, which is found in around 13 to 20% of patients. But this distribution is different in small duct ICC and large duct ICC. In small duct intrahepatic cholangiocarcinoma, we see that around 12 to 40% of patients have IDH1 or 2 mutation, while in large duct intrahepatic, it is only 0 to 5.3%. While the other important mutations, that is FGFR2 mutation and KRAS mutations, are around 11 to 14% and 11 to 8%. Now, FGFR2 mutation is more common in small duct cancer, and KRAS mutation is much more common in the large biliary duct cancers. Then coming on to the perihilar cholangiocarcinoma, we see that the most common is TP53 mutation, followed by KRAS mutation, and then HER2 mutation. And in distal cholangiocarcinoma, the most common are KRAS mutation, TP53 mutation, and HER2 mutation. Next slide, please. So this is a tabulation of these same findings, including other mutations also. So we can see that PIK3 mutations are also very common. And then KRAS substitutions are an important finding in most of the cases. Then CDKN2 mutation is also there in 27% of patients in intrahepatic cholangiocarcinoma, according to one study in 2016. Next. So there is always a question as to when to do molecular testing in intrahepatic cholangiocarcinoma. So as I already have told that we prefer to go for, there could be a variation in the practice among different consultants or different doctors, but we prefer to go for upfront molecular testing in intrahepatic cholangiocarcinoma. We understand that there is a difficulty or challenge which we come across in getting biopsy samples. Sometimes we may be having brush biopsy, or the needle biopsy is inadequate for molecular testing. But we try to get an adequate sample, and we usually go for the actionable mutation profile as soon as possible. Next slide. Next. So we understand that there are challenges, but we now have the option of liquid biopsy. And next, we can go for liquid biopsy, as was discussed by Dr. Amit in the previous presentation. And it gives a good possibility of getting adequate samples and finding out the targetable mutations. Next. So discussing about the advantages and pitfalls of ctDNA or liquid biopsy. Basically, ctDNA has to be taken from blood and bile, and it is very much possible, easily doable. So it helps in comprehensive genomic profiling in patients with cholangiocarcinoma. And NGS of cell-free DNA or ctDNA extracted from serial biopsies can provide insight into tumor heterogeneity, tumor burden, metastasis, and clonal tumor evolution under therapy. The advantage is the ease and the frequency with which liquid biopsies can be taken, so serial biopsies can be done. The disadvantage is that ctDNA may constitute only a small fraction of the total cell-free DNA isolated. And as an evidence, in a large patient cohort with biliary tract cancer, when concordance was seen between cell-free DNA and tissue for mutation detection, it was high for IDH1 mutation with 87% concordance. BRAF V600E was 100% concordant, and it was low for FGFR2 fusion with only 18% concordance. However, when we are lacking a tissue biopsy or the possibility of tissue biopsy does not exist, we should go for liquid biopsy. Next slide, please. So this is a chart which shows the timeline of development of therapies in biliary tract cancer. So till 2010, we did not have any standard of care. In 2010, we had gemcitabine cisplatin, which was seen to be improving the survival. And then we have in 2018, S1 being discovered and found to be superior, giving a superior result in combination with gemcis. Then there was smallpox, and in 2020, we had our first targeted therapy, which was seen to be of some use in biliary tract cancer, which was pemigatinib. Then we have infigratinib, ivosidenib, and then we now have dabrafenib, trametinib, trastuzumab, and of late we have futibatinib, which was marketed in 2022. In 2023-24, we had Keynote 966, which was an important addition. Then we had tucatinib, trastuzumab, deruxtecan for HER2 mutation positive tumors. So now we have greater number of choices, but we need to have a targetable mutation, and then only can we use them. So we will see for the evidence in the next slides. Next. So we now discuss the IDH1 and 2 mutation pathway in cholangiocarcinoma, which is one of the most important targetable mutation with a therapeutic drug present for us. Next. So basically what IDH1 and 2 does is it catalyzes, oxidative recarboxylation of isocitrate to alpha ketoglutarate in the TCA cycle or the Krebs cycle. In absence of IDH1 or IDH2 wild type, there occurs an alteration in the cellular metabolism and the epigenetic regulation in the cell, which leads to ultimately oxidative defect and DNA repair defect. Next slide, please. And this next slide. Next slide, please. So basically, this altered IDH functioning leads to dysregulation in epigenetic functioning of the cell, which leads to increased histone methylation and DNA methylation. There is altered cell differentiation, which leads to immature cells developing and ultimately lead to proliferation of immature cells and tumorigenesis. Also, there is altered DNA damage repair, leading to increased tumor frequency. Next. So this is what I have already discussed, means basically there is lack in cellular differentiation leading to tumor proliferation and metastasis development. Next. So we have, so basically the first study, which was phase 3 trial to be done. Go to the previous slide, please. Previous slide, please. So basically, the first study to be done in cholangiocarcinoma to target was a Clarity study, which was based on IDH1 targeting agent, that is ivosidenib, and it was a phase 3 randomized controlled trial, which was multi-center trial, and it was having a long follow-up study, and it was done in patients who had already received one or at least one cycle of chemotherapy. So it was not done in first line. It was done in patients who failed on chemotherapy, and uh, then it was added with chemotherapy or was given alone. Uh, so a set of around 126 patients was taken in the target group, and the control group had 61 patients. So it was a distribution of patients in 2:1 frequency, and they were followed up for a period of about 3 years. And then we can see in this Kaplan-Meier graph that overall survival probability was increased from 7.5 months, which was median OS in placebo, to 10.3 in the uh, test group. So there was a relative difference, significant difference of about 5.1 months when it was adjusted for uh, uh, RPSFT, and there was a relative HR of the HR was around 0.49. Next. So basically, there were two important subgroups. The first, which had received one line of therapy, and
Sorry to interrupt, sir. Sir, 2 more minutes left in the session. Thank you.
so there were two sets of patients with one line of therapy and the other with two lines of therapy. So we can see that in those patients who had received only one line of therapy, the overall survival was 14.8 months, which was significantly higher as compared to those receiving two or more than two previous lines of therapy, where it was only 7 months. Compared to the placebo group, we had a significant advantage in of about 2.5 months. Next slide, please. So if you see that 6 months PFS rate was 32% in the ivosidenib group and only 1.4 months in the uh, placebo group. Next slide, please. So this is the forest plot analysis. We can see that most of the groups had a significant hazard ratio in favor of ivosidenib. So it didn't matter whether it was one line of therapy or two lines of therapy. In locally advanced disease also, we did get some benefit. In the metastatic setting, there was a clear benefit. Next. So there weren't any major safety signals. There was uh, not much discontinuation due to treatment emergent adverse reactions. The most important toxicities were around nausea, diarrhea, fatigue, abdominal distress. So these are not very troublesome, and around 37.3% of patients had more than or equal to grade 3 toxicity, which the common were ascites, anemia, and blood bilirubin increase. Next. Next. Next slide, please. Next. So we must understand that whatever targeted agent we are giving, this is for IDH1 mutation. There were ultimately there was a development of resistance after some time, and there was a regrowth of the tumor because of intrinsic mutations developing in IDH1 or PIK3CA mutation pathway. Next. Next. So there was an effort to find out the efficacy of ivosidenib with combination of Gemcis in the phase 1 in the first line setting also. This study is still ongoing, but we do not have a conclusive evidence of its benefit. But still, yes, it is a tolerable regime as per the data we have. But the trials are still ongoing. Next slide, please. And then there was an effort to see if IDH1 mutant patients have a poor response with the durvalumab. So it was seen that these patients do not, though these patients form a very small number, that is around 8 to 9% of patients have IDH1 mutation, but these patients do not have inferior outcome uh, as compared to the non-IDH mutant patients. Next slide, please. So next slide, please. Next. So the next important mutation are FGFR2 fusions in cholangiocarcinoma. Basically, this is a fusion between FGFR2 gene and DICC1 gene at breakpoint, forming a fusion mRNA FGFR2 DICC1, and it is found in around 5 to 10% of patients. Next. So we have two classes of FGFR2 mutation inhibitors. One is reversible, the second is irreversible. The reversibles are pemigatinib, infigratinib, which are available clinically now, and the reversible is futibatinib. Obviously, the irreversible binding is by covalent binding, and these inhibit kinase activity. One reversible one would do it reversibly, the reversible ones do it irreversibly. When a reversible inhibitor is used, it may lead to drug resistance mutations, which may develop very quickly. Next. So this is the comparative table. We have three important drugs: pemigatinib, infigratinib, futibatinib. The trial for pemigatinib was FIGHT 202, and for infigratinib NCT 02150967, and futibatinib Phoenix CCA2. Next slide, please. So FIGHT 202 was a single-arm study with pemigatinib. There were three cohorts: FGFR2, one with mutant FGFR2 fusion or rearrangement. In the other cohort was where there were some different alterations, and the third cohort was of normal patients. Pemigatinib was given 2 weeks on, 1 week off, and the primary endpoint was overall response rate, and the secondary endpoints were duration of response, PFS, OS, TCR, and safety. The median follow-up was for about 3.5 years. Next. So we can see this is the waterfall plot, and we can very well see that around 90% of patients have had a response, and the overall control rate was 37%, while disease control rate was 82%. Though the complete response rate was only 3%, partial response being 34%, but median duration of response was good enough as compared to ivosidenib. It was 9.1 months with a PFS of 7 months and a good overall survival of 17.5 months. So around 82% patients has a disease control. Next. So the important safety information is that most of the FGFR inhibitors cause hyperphosphatemia because of the uh, bystander effect, and they can also cause alopecia, diarrhea in a significant number of patients. However, no deaths were there because of treatment-related complications, and overall, only 10% of patients had to discontinue treatment due to treatment emergent adverse events. Hyperphosphatemia was found in a significant number of patients, and around 15% of patients had grade 3 or more hyperphosphatemia. Next. Then there was Phoenix study, which was done for futibatinib, and it had a similar population with unresectable or metastatic intrahepatic cholangiocarcinoma FGFR2 fusions, equals 0 or 1, and progression after more than or 1 systemic therapy. So there was a follow-up for about 2 years. The primary endpoint was the same, overall response rate. Next. And it also showed a very good disease control rate of around 82%. Next. And here also we can see that the most important complications were same: hyperphosphatemia, alopecia, dry mouth, and grade 3 reactions, which are most common, were hyperphosphatemia in this case also. Next. And this is one of the newer drugs, RLY 4008, which has shown a disease control rate of about 100% when it was given 70 mg every day. And in lower doses, there were lower responses, but very significant 90% plus response rate. Next. So we come to the other mutations. We know BRAF V600E mutation is also there. It occurs in about 5% of cholangiocarcinoma. Dabrafenib trametinib combination is useful for it. Overall, response rate is 47% with a very good response, rapid response in aggressive disease. And it is now included in NCC and ESMO recommendations. Next. And then we have HER2 amplified cholangiocarcinoma. We have very familiar molecules, TRAS2, PER2, TRAS2 deruxtecan, and tucatinib combinations. There are ongoing trials evaluating antibody drug conjugates and dual blockade. Next. Then we have NTRK and RET fusion positive cholangiocarcinoma. We have tissue agnostic approvals for larotrectinib and entrectinib, sulfatinib, and these show good durable responses with a response rate of about 60 to 75%. Next. And then we have MSI high, means we do MSI testing in all the patients of cholangiocarcinoma. Those who have high MSI or MMR deficient disease, pembrolizumab has a tissue agnostic approval in such cases, and it has a very good high response compared to chemotherapy. Next. And then we have KRAS G12C positive cholangiocarcinoma. Sotorasib and adagrasib are approved for this disease. And there are investigations, there are trials going on for KRAS G12D also. Next. And then there are combination strategies which are now coming up, in which we mainly see FGFR inhibitors with immunotherapy, IDH inhibitors with PARP inhibitors, and HER2 blockade with chemotherapy. The rationale is to overcome tumor immunogenicity, enhance tumor immunogenicity, and to overcome resistance. So thank you. If there are any questions, I'd be happy to take.
Thank you very much for the presentation, sir. It's only because of less time I feel that you have skipped and less explained few things. But anyway, the presentation was comprehensive. We couldn't listen it further. To add, FGFR mutation has given the best overall survival among the trials, and HER2 positive and HER2 inhibitors have given the better response rate. Very soon, I think that these come into first line and sometimes even an adjuvant too. That's how the trend has been moving on in oncology. The problem is there are two problems in biliary tract oncological trial design. First thing is that the cancer is not as common as it is in Southeast Asia when compared to the Western countries. And doing a phase 3 trial requires a lot of population. I think that's one thing where which is inhibiting the evidence to come up as fast. So our next speaker is a renowned medical oncologist in Hyderabad, Dr. Vinja Vasini Madam. So we will be discussing about the elephant in the room, the TOPAZ trial, and the role of immunotherapy. Thank you, Madam, for accepting. And there is a time constraint, but I think you can concise and present it as soon as possible. Vinja Vasini Madam is a senior medical oncologist at Omega Hospitals, Hyderabad. I now hand over the mic to her to explain about TOPAZ trial, role of immunotherapy, and other aspects of biliary tract cancer. Thank you very much, madam.
Yeah, thank you very much, Dr. Gautam, for the kind introduction, and thank you IAIO for arranging this meeting this evening. I hope my slides are visible. So without much delay, I'd like to start my presentation today. So I'd be discussing about the role of immunotherapy and how it has changed the long-term survivals in this difficult to treat cancer, that is biliary tract cancers. I would go through initially about the evolution of the first line treatment, followed by how immunotherapy has helped in extending the survival in biliary tract cancers, and some real world evidence about IO in BTCs and then the summary. So prior to immunotherapy in 2010, the ABC02 study evaluated gemcitabine plus cisplatin against gemcitabine single agent, and this was established as the standard first line chemotherapy for advanced biliary tract cancers. So since then, gemcitabine cisplatin continues to remain the standard of care, with no new therapies improving the outcomes in advanced BTC for the next decade. So then, because of the hematological toxicity and the renal toxicity of cisplatin, oxaliplatin was evaluated in place of cisplatin as a doublet chemotherapy, and this was a small study published by our Indian colleagues from TMH, which concluded that gem-cisplatin or gem-oxaliplatin can be used as initial regime because each has its own benefits and toxicities, but both were similar. Then this was the AIM study, which also was a single center study, open label trial evaluating GEMOX versus GEMCIS, and they concluded that both had numerically similar survival. GEMOX had a numerically better survival compared to cisplatin, but the trial failed to show equivalence of 8 cycles of cisgem to 6 cycles of GEMOX. Nonetheless, both GEMOX and GEMCIS remained as standard of care then. Then came the evaluation of triplet regime, that is GEMCIS and nab-paclitaxel. This was a phase 2 trial which showed that the median PFS was 11.8 months and the median OS was 19.2 months for the triplet regime in advanced biliary tract cancers. But this was a small study including only 60 patients, and median number of cycles was 6. Overall response rate was 45% and 84% disease control rate. This was followed up by a larger phase 3 trial which evaluated the triplet versus the doublet in newly diagnosed advanced biliary tract cancers, and it concluded that there was no statistically significant improvement in the median overall survival with triplet. It only increased the toxicity, but specific patients like patients with locally advanced disease and gallbladder cancer may benefit from the use of this triplet regime versus other sites of disease. Then came the IO era, which has now established as the preferred standard of care. Chemotherapy plus IO, either durvalumab or pembrolizumab, has now become the category 1 recommendation. So this recommendation is based on the pivotal trial, that is the Topaz 1 trial, which is the first trial evaluating IO in combination with chemotherapy in advanced biliary tract cancers. So the Topaz trial, it was a multinational trial, and the important point is it included India as one of the centers, and around 24 patients in the Topaz clinical trial were recruited from India, and a lot of Asian population is also represented in this study. So when we look at the study design, it is a phase 3 trial which evaluated Durva plus GEMCIS compared to placebo GEMCIS in the first line unresectable BTC, and the randomized around 685 patients were randomized 1:1 to the experimental durvalumab once in 3 weeks plus GEMCIS up to 8 cycles versus placebo and GEMCIS, followed by maintenance until progression. Stratification was based on the disease status, either initially unresectable or recurrent disease, and based on the primary tumor location, intrahepatic versus extrahepatic versus gallbladder. Primary endpoint was overall survival, and the key secondary endpoints were PFS, ORR, duration of response, patient-related outcomes, safety, biomarkers. When we look at the patient demographics, they were fairly well matched. Around half of the patients, more than half of the patients were from Asia, and the median age was 64, equal number of males, females, and then when we look at the primary tumor, around a quarter of the patients had gallbladder, around 20% had extrahepatic cholangio, and more than 50% had intrahepatic cholangiocarcinoma, and majority of the patients had metastatic disease. compared to only 11 to 16% who had locally advanced disease. When we look at the primary endpoint, that is the 3-year overall survival analysis, it showed that the median overall survival in the durvalumab plus gemcis arm was 12.9 months, that is just over a year, compared to 11.3 months for the placebo plus gemcis, but this was statistically significant with a hazard ratio of 0.74. More importantly, when we look at the longer responses, like at 24 months and 36-month overall survival, we see that the curves keep separating. At 24 months, around 22.9% of patients on durvalumab plus gemcitabine were alive, compared to only 13% in the control arm. And when we look at the 36-month overall survival, it is 14.6 months for the durvalumab arm compared to 6.9 months for the control arm. So the gap is maintained, or the curves remain separated for a longer time. When we look at the subgroup analysis, all patients, irrespective of their gender, age, PD-L1 expression, the primary location of the tumor, and performance status, and the diagnostic stage, either locally advanced or metastatic, they benefited with the addition of durvalumab to chemotherapy. Now let us look at few of the secondary endpoints. The PFS, again the median PFS was 7.2 months for durvalumab plus chemo compared to 5.7 months. The statistical significance cutoff was a p-value of 0.048, so the p-value was significant with the hazard ratio was significant. And also at 12 months, 12-month PFS was 16%. So 16% of the patients on durvalumab continued to show response at 12 months compared to only 6.6% in the control arm. And when we look at the overall response rate, more number of patients in the durvalumab arm had responses. The objective response rate was around 26.7%, with almost 2% of patients showing complete response in the durvalumab arm, and whereas it was only negligible 0.6% in the chemo alone arm who had complete responses. And when we look at the disease control rate, it was 85% for durva plus chemo versus 82.6% for the chemo arm. And also duration of response, which is very important. The median duration of response was 6.4 months for durva gemcis compared to 6.2 for placebo plus chemo. Importantly, when we look at the Kaplan-Meier curve, we see that the number of patients remaining in response for beyond 1 year is significantly more. It is 26% in the durvalumab arm compared to only 15% in the chemo alone arm. And when we see that these curves are separating early at 3 months, showing that there is increased early response to immunotherapy in these patients. So when we look at the overall survival by best objective response, we see that among responders, so these curves are slightly confusing. The first two curves, so the light yellow and the dark maroon curves are the complete and partial responses. The dark maroon is the durvalumab plus gemcis arm patients who had complete response or partial response to treatment, and they showed the best overall survival. So among responders, there was a clear and sustained separation of the curves beginning approximately 15 months. So we see that the curves separate at a later date, almost more than a year after on the treatment, after randomization. So they respond late, but as we follow the graphs, the curves remain separated for long. Similarly, among participants with the best objective response of stable disease, there was a sustained separation between the curves at approximately 6 months. So the second set is the stable disease. The third set is the progressive disease, which obviously did bad in both the arms. So patients who responded to immunotherapy had a significantly longer survival compared to patients even in patients who responded to chemo alone. So as responses are important, so are the adverse events. Any adverse event and any serious adverse event occurred in approximately 99% and 47% in the chemo immuno arm compared to 98.8% and 43%. And as expected, immune related adverse events were more common in the chemo immuno arm, and they were fairly well tolerated. So most of these adverse events were related to the chemotherapy component, and they were easily managed. So when we look at the overall survival and the immune mediated adverse events, the overall survival for durvalumab compared to placebo for participants with and without an adverse event was similar, and the benefit was observed irrespective of the occurrence of adverse event. So there was a evaluation of the mutation status on the efficacy outcomes. So as expressed by previous speakers, the mutations landscape as we have seen is different for different locations, and the genomic alteration prevalence differed by the primary tumor location and was consistent. The majority of the most common alterations are observed across all anatomic locations, and irrespective of the presence of these mutations, durvalumab plus chemotherapy was effective in all the participants with clinically actionable and high prevalence genomic alterations. And generally similar overall survival benefit with durvalumab versus placebo was observed for participants with either wild type or altered genotypes of these genomic alterations. And brief about the other immunotherapy, that is the Merck's Keytruda. So here the Keynote 966 trial evaluated pembrolizumab plus chemo, and it was a similar trial. And the overall survival, the primary endpoint was also overall survival. The 3-year overall survival was around 12.7 months versus 10.9 months, which was similar, but statistical significance was not reached. So now let us look at some of the real world evidence. So there were several real world data published starting from the Italian study, then also we also have our Indian data. So here the Italian early exploratory analysis of the real world data from Italy was presented. Around 145 patients were evaluated, and it showed that the median PFS was 8.9 months and median overall survival was 12.9 months, reflecting similar data to the TOPAZ-1 trial. And durvalumab plus gem and cisplatin in advanced biliary tract cancer showed similar outcomes in the real world compared to the trial data. And adding durvalumab seems to improve the overall response rate as per the real world data as well. Now this is the Indian study which included around 12 centers all across the country. Around 145 patients were included. Notably, higher proportion of gallbladder malignancies were included, and patients with performance status 2 or higher were also included, which is most common in the real world setting. And majority were de novo metastatic disease. In spite of such aggressive tumors, the median PFS and the overall survival data matched the TOPAZ trial, and it was consistent with the TOPAZ-1 trial outcomes. And the adverse events again were as expected, nothing new, and they were fairly well managed. So the real world conclusion was real world evidence also extrapolates the survivals from the pivotal trial data with median overall survival of around 12 months and PFS of 8.2 months. There are no new safety data, and patients with poor performance status also seem to tolerate the addition of durvalumab well, which is a very important point to note. And the Indian data confirms that gallbladder cancers also perform reasonably well with the addition of durvalumab to the standard chemotherapy. So to summarize, Topaz 1 trial and the Keynote 966 establishes extended survival benefit of IO plus GEMSIS in the first line management of unresectable biliary tract cancers. And the addition of immunotherapy does not worsen the toxicity profile and showing comparable safety across both the treatment arms. Durvalumab plus GEMSIS is effective in patients with clinically actionable and high prevalence genomic alterations, and the real world evidence both across the world and in India, from India, confirm that the addition of Durvalumab to standard chemotherapy improves the outcomes for gallbladder cancer. So, where do we stand with the immunotherapy in advanced BTC? Right now, the standard of care is immunotherapy plus chemotherapy, either Durvalumab or pembrolizumab. As of now, single agent immunotherapy, that is pembrolizumab, is limited to MSI high tumors only, and there is no validated predictive biomarker for the inclusion of immunotherapy. And there is an indirect comparison of Topaz 1 and the Keynote 966, which shows that Durvalumab has a clinically meaningful benefit, whereas pembrolizumab has a modest benefit, with maintenance gemcitabine being a confounding factor in the trial. And Durvalumab has changed the global standard of care with the outcomes of the Topaz 1 trial. And what are the strengths and limitations of using immunotherapy in biliary tract cancers? So it is the first positive phase 3 trial showing improvement in the overall survival and progression-free survival. This consistent OS and PFS benefit, and there is good validation from the real world evidence. But the limitations are the overall survival gain is modest of only 1 to 2 months. There are no predictive biomarkers to exactly predict who would benefit from the use of immunotherapy. And of course, there is a high cost involved, and still chemotherapy remains the backbone. We cannot totally eliminate chemotherapy as of now. So, in conclusion and the future directions, currently Durvalumab plus GEMSIS remains the standard of care, with pembrolizumab as an alternative IO option. There are no biomarker driven selections yet, and maybe in the future IO plus targeted therapy or IO plus anti-VEGF may be included, and there is a shift towards precision immunotherapy as discussed in the previous speakers. So I thank you for your patient listening, and I now hand over the session to the organizers and back to Dr. Gautam.
Thank you very much, madam. It was a cherry on the cake presentation at the end of the seminar. It had led into insight, but we had a discussion in the beginning. Would you like to continue durvalumab in spite of progression, especially oligoprogression? This was a question, or they have continued it, but because of experience, I thought that your experience would add to our clinical knowledge. In case of oligoprogression, would you like, because these patients have less PFS, but their overall survival improved over a period of time. Means that there is a lot of after effect also. But if it permits, would we like to continue durvalumab in spite of progression, at least oligoprogression?
In oligoprogression, definitely I would like to continue and give the benefit of immunotherapy, because we know that these immunotherapy molecules, their mechanism of action and their responses are not similar to the chemotherapy. Though there is a progression, there might be an improvement or benefit in the overall survival. So I would definitely like to continue durvalumab and maybe change the chemotherapy partner, or if there is a progression where we can give some local therapy, then use that local therapy and continue immunotherapy rather than discontinue.
I think a similar approach has been followed by a previous presenter, and I think that's most real world approach that we usually follow in our usual practice. And within a few years, I think there will be some kind of predictive score or kind of optimization of who should receive immunotherapy and who should not receive immunotherapy. Because as seen by the survival curves, there is one specific population among biliary tract patients who actually benefit from immunotherapy. Identifying those patients and treating them aggressively would actually help in managing the cancer better. With this, I think it is the most comprehensive presentation of biliary tract cancers. And again, rather than knowing about what and what and how, we understood why the treatment is done as it is being done in biliary tract cancer. One, the take home philosophy of the entire presentation is don't just treat the tumor burden, treat the biology and the biliary physiology. And it has not been mentioned in the things, but palliative and supportive care forms a major role in managing biliary tract cancers, at least in countries like India, because that is what which determines the survival of the patient immediately. And again, cholangitis is one of the major complications that we routinely see. Uh, just to add things up or closure, the most common antibiotic that we use in cholangitis is piperacillin tazobactam is the first line. If it doesn't work, we go with meropenem. If it doesn't work, we add vancomycin in case of MRSA and all those things. This is important because we, in practice, people get admitted with cholangitis lot and lot of times, and biliary draining should be done as early as possible in the treatment course, because we are not treating the disease, we are treating the patient, and we need to think all over. And we should use other modalities like SBRT for in case of oligoprogression in the lung. And right now, a lot of brachytherapy applications are coming where we can go inside and treat the tumor in case of surgical resectability or not. Again, there have been some patients whom they have started with chemoimmunotherapy, they have responded wonderfully and they became resectable. And I have seen few patients of mine or known to me in this paradigm. Thank you very much. And thank you for International Association of Integrated Oncology. It has been a wonderful presentation and all the presenters have done their best. Again, organizing such kind of event in the late night is not so easy. I thank for the IT team for their coordinated work, and all the main people of Integrated Association of Oncology, International Association of Integrated Oncology, coordinating such a beautiful, well crafted and well drafted seminar on biliary tract cancers. Thank you very much.
Thank you, sir.
Thank you everyone. Have a great evening.
Thank you all. Thank you, presenters. Thank you.